the deep dive. We're here specifically for you, the learner, and today, well, we've got a set of source materials we're going to break down.
That's right. It's basically a review session, looking at practice questions like you'd see for the USMLE exams, step 1, 2, 3.
Yeah, and our mission is really to unpack how these tricky medical concepts get presented in that testing format. We want to give you a bit of a shortcut to some really useful insights.
Absolutely. We're not just about finding the right letter answer. We want to dig into the clinical setups, the science underneath, and, crucially, the thought process. How do you connect the patient's story to the underlying medicine?
Exactly. So let's dive in and pull out the important stuff for you. Ready for the first one?
Let's do it. Question 21. Okay, so we have a 65-year-old woman. She comes into the ER. Classic signs of a possible heart attack, chest tightness, pain down the arm.
Okay, sounds like an acute MI. What else?
Well, the labs show elevated troponin I. ECG changes confirm it. But the physical exam is key too. She's got JVD, jugular venous distension, and crackles in her lungs.
Ah, JVD and crackles. Signs of backup.
Exactly. And the question uses one of those cardiac function curves, plotting cardiac output against end diastolic volume, and asks, where would this patient be right after the MI?
Okay, so thinking physiologically. MI means the heart muscle is stunned, ischemic. It can't contract properly.
Right, so the pump is weaker. Fundamentally, cardiac output has to go down. Less blood is getting pumped out per beat.
Makes sense. Pump failure equals lower output. But what about the end diastolic volume part? That's where the crackles and JVD come in, right?
Precisely. If the left ventricle isn't pumping blood forward effectively, where does it go? It backs up.
Backs up into the lungs first.
Into the lungs, causing that fluid transitation you hear as crackles. Then it backs up further through the left atrium, pulmonary veins, right heart, and eventually into the systemic veins, hence the JVD.
So all that backed up blood means more volume is left inside the ventricle at the end of filling, before it even tries to pump.
Exactly. That's your end diastolic volume, or preload. Because the pump is failing, the preload increases. The ventricle is overfilled because it couldn't empty properly.
Got it. So on that curve, we need the spot that shows decreased cardiac output and increased end diastolic volume.
That's the one. The clinical signs directly point you to the physiological changes on the graph. It all fits together.
Okay, clear. Let's switch gears completely. Question 22, psychiatry.
Right. This is a 33-year-old woman.
Yeah.
She's been brought in because she was stalking the president.
Stalking the president. Okay. What are her symptoms?
She has some pretty significant grandiose delusions. Thinks she's married to his twin. Claims she's getting divine instructions. Her speech is really rapid. Hard to get a word in. Jumps from topic to topic.
Loose associations or flight of ideas?
Yeah, flight of ideas seems likely with the rapid speech. Plus, she hasn't slept much for days, reports hearing voices, and this whole picture's been going on for 2 months.
Wow. Okay, so the challenge is the diagnosis. Options are brief psychotic disorder, delusional disorder, maybe a medical cause, schizophrenia or bipolar disorder.
There's a lot there. The delusions and hallucinations are clearly psychotic features. But what else stands out?
Well, the decreased need for sleep, the rapid speech, the flight of ideas, the increased activity. I mean, stalking the president is pretty goal-directed, albeit delusional. That sounds manic.
Exactly. The source material emphasizes looking at that whole constellation. Grandiosity? Check. Decreased sleep? Check. Talkativeness? Pressured speech? Check. Flight of ideas? Check. Increased activity? Check.
Is this where that mnemonic comes in? DI'd fast.
Yes. DI'd fast. Distractibility, impulsivity, indiscretion, grandiosity, flight of ideas, activity increase, sleep deficit, talkativeness. She hits a lot of those. Strongly suggests a manic episode.
So it's mania with psychotic features. How does the 2-month duration help narrow it down?
Okay, duration is key. Brief psychotic disorder is, brief, less than a month, so that's out.
Right.
Schizophrenia typically needs symptoms for 6 months or more for diagnosis and often has negative symptoms or different core features, not necessarily this prominent manic picture.
What about delusional disorder?
Delusional disorder is usually characterized by a fixed false belief. But without all these other mood symptoms and widespread functional disruption we see here, she's got way more than just a delusion. And nothing suggests a medical cause.
So 2 months of clear manic symptoms plus psychosis. Sounds like bipolar disorder, currently in a manic episode with psychotic features.
That's the most likely diagnosis based on the full picture. You have to integrate all the symptoms, not just focus on the psychosis alone.
Makes sense. Okay, question 23 is different again. It's about communication.
Yeah, ethics and communication. The scenario is a physician telling parents their newborn has Down syndrome. The physician gives the essential news immediately, but decides to hold back on more detailed info for later.
And the question is, why do that? What's the purpose of that approach?
Well, think about receiving news like that. It's incredibly emotional, potentially devastating.
Yeah, you'd be in shock, probably not thinking clearly.
Exactly. The source points out that intense emotional states significantly reduce a person's ability to process complex information. They might hear the words, but they won't really absorb the details.
So the doctor is trying to ensure they grasp the most critical piece first.
Precisely. The immediate goal is comprehension of the diagnosis itself. Dumping tons of information about associated conditions, therapies, resources, prognosis, all that important stuff right at that moment might just overwhelm them and none of it would stick.
So it's not about hiding things or delaying bad news.
Not at all. It's about managing the flow of information to match the parent's likely emotional and cognitive state at that moment. It prioritizes immediate understanding of the core issue.
Okay, that's a really important communication strategy. Let's move to question 24, urology territory.
Yep, 62-year-old man. Classic lower urinary tract symptoms. Hesitancy, trouble starting the stream, post-void dribbling, waking up at night to urinate nocturia.
Sounds like BPH. What about the exam?
Prostate exam shows a diffusely enlarged, firm prostate. Fits perfectly. There's a bit in the history about him being a retired lab tech working with naphthylamine.
Which the source called a red herring for BPH itself, right? Though may be relevant for other things.
Exactly. For BPH, that's likely a distractor. The question asks about the most likely contributor to the development of his BPH. What's the underlying pathophysiology?
Okay, so what actually makes the prostate grow in BPH?
It's hormonally driven. The main culprit is dihydrotestosterone, DHT.
DHT, that's converted from testosterone, isn't it?
It is. By the enzyme 5-alpha reductase, testosterone gets converted to the much more potent DHT within the prostate cells, and DHT drives the growth, the hyperplasia.
And that's why some BPH drugs block that enzyme.
Exactly. Drugs like finasteride or dutasteride are 5-alpha reductase inhibitors. They reduce DHT levels in the prostate, can actually shrink the gland over time.
Okay, but there are other drugs too, like alpha blockers.
Right, like tamsulosin. Alpha-1 blockers work differently. They relax the smooth muscle in the prostate and bladder neck, which helps relieve the symptoms of obstruction, improves the flow. Yeah. But they don't address the underlying growth. They don't shrink the prostate.
So the question is about the development of the condition, the growth itself.
Which is primarily driven by that conversion of testosterone to DHT. So increased 5-alpha reductase activity leading to more DHT is the fundamental contributor to the hyperplasia. The alpha receptor activation contributes more to the symptoms.
Got it. Development versus symptoms. Key distinction. Okay, next up, question 25, trauma.
Yeah, a 19-year-old man, knife wound to the right side of his chest. He's in distress, tachycardia, tachypnea, a bit hypoxic. And critically, his trachea is shifted away from the injured side, so shifted to the left.
Tracheal deviation after chest trauma. That's alarming. Sounds like a tension pneumothorax.
Absolutely textbook. Air is getting into the pleural space on the right, likely through the lung injury, and it can't get out. Pressure builds up, collapses the right lung, and pushes the mediastinum, the heart, trachea, everything over to the left. It's an emergency.
So the question asks for the expected physical exam findings on the injured right side. What would we find?
Okay, let's think about what happens when you have a big collection of air instead of functioning lung tissue under the chest wall.
Breath sounds first.
Definitely going to be decreased or completely absent on that right side. Air doesn't conduct breath sounds well, and the lung underneath is collapsed.
Okay. What about percussion? Tapping on the chest.
Instead of the normal resonant sound over lung tissue, tapping over trapped air gives you a hyper-resonant sound, like tapping on a drum.
Hyper-resonant. Got it. And tactile fremitus. Feeling the vibrations when he speaks.
Also decreased. Just like sound transmission for breath sounds, the vibrations from the voice box don't travel well through that insulating layer of air in the pleural space to reach your hand on the chest wall.
So putting it together, decreased breath sounds, hyperresonance to percussion, and decreased tactile fremitus.
That's the classic triad for a pneumothorax. And with the tracheal deviation, it points strongly to a tension pneumo. The source emphasizes tackling these multi-part questions finding by finding.
Good strategy. Okay, question 26. This looks like genetics and endocrine stuff.
Right. 34-year-old man. He's got diarrhea, a history of having a pheochromocytoma removed.
Pheoadrenal medulla tumor.
Okay, and his mother had a parathyroid gland tumor. Now, he has a neuroendocrine neoplasm of the parafollicular cells in his neck.
Parafollicular cells. C cells. That means medullary thyroid cancer.
Correct. So the constellation is pheochromocytoma history, parathyroid involvement, family history suggesting predisposition, and medullary thyroid cancer, current.
That pattern really rings a bell for multiple endocrine neoplasia, or MNN syndromes.
Absolutely. The source lays these out clearly. MNN type 1 involves the menin gene, which is a tumor suppressor. The classic MEN1 tumors are parathyroid, pituitary, and pancreatic. Think parapanc.
Okay, so this guy doesn't fit MEN1. He's got pheo and medullary thyroid, not pituitary or pancreatic.
Exactly. This pattern, parathyroid, history predisposition, pheochromocytoma, and medullary thyroid cancer, is the hallmark of MEN type 2A.
And MEN2 syndromes are linked to a different gene.
Yes, both MEN2A and MEN2B are caused by mutations in the ROET gene. MEN2B also has pheo and medullary thyroid cancer, but instead of parathyroid tumors, it features mucosal neuromas and a marfanoid habitus. This patient profile is classic MEN2A.
So the question is asking about the type of gene mutation, and we know it's in the RET gene for MEN2A. What kind of gene is RET?
The source identifies RET as a proto-oncogene.
Proto-oncogene, meaning a normal gene that, when mutated, can drive cancer, like an accelerator.
Precisely. Proto-oncogenes are typically involved in normal cell growth, signaling, and division. When they get an activating mutation, they become oncogenes, essentially telling the cell to grow and divide uncontrollably. RET is a receptor tyrosine kinase involved in signaling pathways, so this fits.
As opposed to a tumor suppressor gene, like menin for MEN1, which normally acts like the brakes.
Exactly. Tumor suppressors normally inhibit growth, so losing them removes the brakes. RET mutations in MAN2 are gain of function, stepping on the gas. The source also mentions, interestingly, that other types of RET mutations, often loss of function, are linked to Hirschsprung's disease.
Fascinating how one gene does different things. Okay, question 27, another emergency situation.
Looks like it. 56-year-old man, history of hypertension, sudden severe upper back pain. He becomes comatose.
Oh, what else?
Big blood pressure difference between his arms. Decreased pulse in his left wrist, and then neurological signs. On the left side, he has Horner syndrome, droopy eyelid, small pupil, no sweating. But on his right side, he has hemiplegia, weakness.
Okay, that's a complex picture. Hypertension, sudden severe pain, vascular signs like the pulse BP difference, and focal neurodeficits. What about imaging?
Chest x-ray shows a widened mediastinum.
Widened mediastinum plus that history screams aortic dissection, a tear in the aorta.
That's the top suspicion. And the source does a great job connecting all those disparate symptoms to where the dissection might be extending.
Okay, break it down. The pulse and BP difference.
Suggests the dissection involves the aorta, near where the left subclavian artery branches off, compromising blood flow to the left arm.
The Horner syndrome on the left.
That points to disruption of the sympathetic chain, often near the carotid artery origin or in the upper chest. So dissection extending towards the left carotid.
And the right hemiplegia. That means a problem on the left side of the brain.
Likely caused by the dissection compromising blood flow through that left carotid artery, causing a stroke.
What about the hoarseness mentioned in the full scenario?
Ah, yes. Hoarseness often happens if the dissection involves the aortic arch, where the left recurrent laryngeal nerve loops around. Irritation or compression of that nerve affects the vocal cord.
Wow. Okay, so the dissection must be pretty extensive, probably starting proximally, involving the arch and hitting the origins of the left subclavian and left carotid.
Exactly. The combination of left arm, left Horner's, left recurrent laryngeal hoarseness, and left carotid causing right stroke symptoms all points to a dissection extending along the arch and involving those key branches.
Makes terrifying sense. Okay, question 28, back to cancer.
Right. 68-year-old man. History of alcohol use disorder. Main complaint is painless, intermittent hematuria blood in the urine for 3 months.
Painless hematuria is always a red flag for GU malignancy. What are his risk factors?
He has a massive smoking history, 67.5 pack years. And remember that job history. Worked at a company producing naphthylamine.
Ah, naphthylamine again. We said that was a risk factor for bladder-thelial cancer, right? And smoking is huge, too.
Absolutely. Smoking is the biggest risk factor. Naphthylamine is a known carcinogen for this, too. And the CT scan shows a mass, specifically located in the renal pelvis of the left kidney.
Okay, location is key again. Renal pelvis, not the main kidney tissue itself.
Exactly. The renal pelvis is part of the urinary collecting system, lined by urothelium. Cancers arising from this lining, which extends from the renal pelvis down the ureter to the bladder, are called urothelial carcinomas.
Formerly transitional cell carcinoma.
Correct. The terms are interchangeable, but urothelial is current. So, given the location of the renal pelvis and his major risk factors, smoking, naphthylamine, Urothelial carcinoma is far and away the most likely diagnosis.
Much more likely than, say, a standard renal cell carcinoma, which arises from the kidney tubules.
Yes, or other rarer things mentioned as options like angiomyolipoma or oncocytoma. The location and risk factors point directly to urothelial cancer.
Question 29. Looks like a potential PE case.
Yeah. 27-year-old woman, sudden severe shortness of breath right after a long cross-country flight. She's tachycardic, tachypneic, and she has signs of a DVT in her right leg, swollen tender calf.
Classic presentation for a pulmonary embolism originating from a DVT. But she's young, 27. Why would she throw a clot?
That's the core of the question. The flight provides the immobility trigger, Virchow's triad. But in a young, otherwise healthy person, you have to suspect an underlying reason for increased clotting.
A hypercoagulable state.
Exactly. An inherited or acquired tendency to form clots too easily. The source lists several possibilities, things like protein C deficiency, protein S deficiency, antithrombin III deficiency, or factor V Leiden mutation.
It rules out bleeding disorders, obviously.
Right. So among those clotting disorders, which one is the most likely cause in this scenario?
Well, I remember the source mentioning something about prevalence.
Yes. Factor V Leiden mutation is by far the most common inherited thrombophilia in Caucasian populations.
So even though the others are possible, if you have to pick the most likely underlying cause in a young person with an unprovoked or minimally provoked clot like this,
you'll often go with the most common one, factor V Leiden, unless there are specific clues pointing elsewhere. It's a mutation that makes factor V resistant to being broken down by activated protein C, a natural anticoagulant. So the clotting cascade stays active longer.
Got it. Probability favors the most common inherited risk factor here. Okay, last one. Question 30. Neurology.
Right. A 20-year-old woman. She's had progressive arm weakness over 2 months, also some recent back pain and headache, but the really specific finding is sensory loss. Decreased pinprick sensation over her arms.
The source described it as a cape-like distribution.
Exactly. Loss of pain and temperature in a cape-like pattern across the shoulders and arms. An MRI confirms the diagnosis. There's a syrinx, a fluid-filled cavity, in the central part of her cervical spinal cord.
Syringomyelia. That central syrinx explains the symptoms, doesn't it?
It does. The source explains that the syrinx typically starts near the central canal. Right near there are the nerve fibers of the spinothalamic tract that cross the midline, carrying pain and temperature sensation. The syrinx damages these crossing fibers first.
Ah, that's why it's pain and temperature loss, specifically, and often bilateral in that cape distribution.
Precisely. Touch and proprioception travel in different tracks, dorsal columns, and are often spared initially. As the syrinx expands outwards, it can then hit the motor tracts, corticospinal, causing weakness, or even the anterior horn cells.
Then we know what it is and why it causes the symptoms. The question asks what additional history is most important to get. What causes syringomyelia?
It could be congenital, often linked to Chiari-Tyler malformations, where the cerebellum pushes down into the spinal canal, or it can be acquired.
Acquired how?
The most common acquired causes are trauma to the spinal cord, even things like whiplash injuries from years ago or inflammation, like from meningitis or arachnoiditis.
So, given her relatively recent onset of symptoms, asking about past trauma seems really relevant.
Absolutely. The source highlights history of trauma as a key thing to investigate. While family history might be relevant if you suspect a congenital cause like Chiari or recent travel for certain infections, past trauma is a very common precursor to acquired syringomyelia. Diet or weight loss are much less likely to be related.
Makes sense. Explore the most common acquired cause first.
Exactly.
Wow, okay. That was quite a tour. We went from cardiac physiology curves right after an MI
to using mnemonics like DI-JFAS for psychiatric diagnosis, navigating difficult news delivery,
figuring out BPH drivers, predicting trauma exam findings based on air in the chest,
identifying genetic cancer syndromes like MEN2A based on tumor clusters, tracing the path of an aortic dissection through its widespread symptoms,
linking specific cancers like urothelial carcinoma to risk factors and location, pinpointing the most common inherited clotting risk,
and finally understanding spinal cord tracts to figure out why a syrinx causes that specific cape-like sensory loss and what might have caused the syrinx itself.
It really shows how everything connects, doesn't it? You need the basic science, the anatomy, the genetics, the pathology, all to understand the clinical picture.
Absolutely. These practice questions